ختامه مسك. هنبتدي بالدكتورة غادة مسلم، Professor of Clinical Pathology National Cancer Institute. وطبعا احنا بنحب قوي نقول National Cancer Institute ده تبعنا، تبع جامعة القاهرة. بنا في غادة وصراحة وسالي. هنتكلم على موضوع لطيف قوي اللي هو سيل فري دي ان اي ستيم سيل ترانسبلانت. احنا يمكن سمعنا كتير على الفري سيل دي ان اي في السوليد اورجان، لكن ان شاء الله في الستيم سيل ده هيكون حاجه لطيفه. اتفضلي دكتوره غاده.
ميرسي. First of all, I would like to thank the organizing committee for this prestigious conference, and to thank my dear colleague Dr. Rania Bakri for inviting me to give this talk. Our talk today is about the cell-free DNA in stem cell transplantation. مش بيتحرك. مش بينقل. طب ممكن حد بس من مش بينقل. Hematopoietic stem cell transplantation is a gold standard treatment for many benign and malignant hematological disorders. Nonetheless, frequent post-transplant complications, including graft versus host disease or GVHD, which is the attack of the recipient cells by the immunocompetent donor T cells, infection, graft failure, and relapse limit the long-term benefits of transplantation. Early and accurate diagnosis of this complication will help to prevent this serious long-term complication and to inform about different treatment decisions. Cell-free DNA consists of fragmented extracellular DNA released from nucleated cells via apoptosis and necrosis. Cell-free DNA is found in the serum, plasma, urine, and body fluid, and consists of double-stranded DNA, including coding and non-coding regions. Cell-free DNA are short in length, ranging from 70 to 100 base pair. They are rapidly cleared from the circulation by the liver and kidney, with a half-life ranging from 15 minutes to several hours. Cell-free DNA was first described by Mondel et al. In 1948, who described the presence of cell-free DNA in the blood of normal individuals. Then, in 1966, Tan et al. Described the increased elevation of cell-free DNA in patients with lupus erythematosus. Subsequently, in 1977, Lyon et al. Reported the significantly higher level of cell-free DNA in cancer patients compared to healthy subjects, while in 1997 there was a widespread interest in the fetal DNA in maternal blood. Cell-free DNA as a biomarker. Circulating cell-free DNA holds enormous potential as a new class of non-invasive biomarkers in many diseases and conditions. In recent years, cell-free DNA has been studied as a tool for cancer screening and monitoring, prenatal testing, and transplantation. Cell-free DNA fragments retain the information that reveals the tissue of origin and may inform about ongoing pathophysiological processes in specific organs and tissues. Regarding the specimen collection and methods of analysis, the cell-free DNA the sample should be rapidly processed within 4 hours of collection. Methods of cell-free DNA quantitation include the real-time PCR, the more sensitive digital PCR, and the next generation sequencing. Targets of analysis include the DNA index, which is integrity index, which is increased in case of cancer, the identification of specific mutations of rearrangement, specifically in cancer patients. Also, the use of wide genome methylation profiling can inform about the origin of the cell-free DNA. Metagenomic cell-free DNA sequencing has been used for the screening and identification of pathogens in cases of infection. And lastly, chimerism analysis, which can be applied in the setting of stem cell transplantation, which is our topic today. The clinical applications of cell-free DNA includes, as mentioned by Professor Loai, its application an important recent biomarker in cancer. Recently, cell-free DNA shed by cancer cells into the blood, also referred as liquid biopsy, has received a lot of attention for its potential use as a non-invasive tool for early cancer detection, screening, diagnosis, and monitoring. The type of cell-free DNA derived from tumor cells is called the circulating tumor DNA. For cancer patients, monitoring the circulating tumor DNA after surgery also help to develop treatment plans. Recently, cell-free DNA also represents a new paradigm in the monitoring of hematological malignancies. Cell-free DNA-based measurable residual disease assessment is emerging as a powerful tool to identify the presence of residual leukemic cells after treatment. As a prenatal test, cell-free fetal DNA testing during pregnancy, called non-invasive prenatal testing, or NAPT, is a single blood draw that screens for chromosomal abnormalities of fetus while still in utero. The cell-free fetal DNA in maternal blood can detect chromosomal aneuploidies and pathogenic microdeletions as early as 6 to 7 weeks after gestation. In the setting of transplantation, in solid organ transplantation, like in renal transplantation, in heart, biomarkers that provide sensitive monitoring of graft damage provides early indication of rejection in organ transplantation and offer an opportunity to improve therapeutic decisions. The level of donor-derived DNA from the rejected organ increases during acute rejection, weeks to months before histological features of graft rejection in biopsy, as a consequence of cell apoptosis during the process of graft rejection. The analysis of donor-derived cell-free DNA measured in blood or urine, just a sample from blood or urine, instead of taking a biopsy, has received significant attention as a non-invasive method in detecting and in longitudinal follow-up of graft rejection and in monitoring the immunosuppressive therapy. Now, the role of our topic today is the cell-free DNA in stem cell transplantation. Unlike in solid organ transplantation, in the setting of, unlike a solid organ, in stem cell transplantation, different complications may lead to release of cell-free DNA in the circulation, including the graft versus host disease, relapse, and infection. So the origin of cell-free DNA is not only the donor cells as in case of organ transplantation, but may be derived either from the donor, the recipient, or even non-human in case of infection with bacteria, viruses, or fungi. And the origin of this cell-free DNA can inform about specific complications. The presence of cell-free DNA derived from solid organs indicates graft damage and graft versus host disease. The relative proportion of cell-free DNA from the recipient and donor indicates the state of engraftment and early relapse, while tumor-derived cell-free DNA indicates residual disease and relapse, and finally, microbial-derived cell-free DNA indicates infections, so that all these complications could be informed by only a blood sample. Acute graft-versus-host disease, which is an acute inflammatory complication of transplantation mediated by alloreactive donor cells against the immunocompromised recipient, is associated with the organ damage and release of inflammatory activation of inflammatory cells. So the condition is associated with the release of cell-free DNA from both the damaged organ and also from the inflammatory cells involved in its pathogenesis. Tissue-specific methylation pattern can provide not only the elevation of total cell-free DNA as a result of tissue damage, but may also inform the tissue of origin. So, as a biomarker in case of acute graft-versus-host disease, the cell-free DNA presented advantages over protein biomarker by providing an approach to measure injury to any tissue, because other biomarkers are related to certain tissues. Those are related to the GIT, the skin, whatever, but these markers are elevated in any condition. Cell-free DNA may also measured trended over time because the simplicity of the sample allows repeated examination over time. This study reported that testing cell-free DNA, the cell-free DNA level was elevated in patients with acute graft-versus-host disease compared to healthy controls as early as 1 month after transplantation, before the development of frank acute graft-versus-host disease. Not only that, the methylation pattern may indicate the tissue of origin and may indicate the organ affected by acute graft-versus-host disease. Also, chronic graft-versus-host disease, which also an inflammatory complication of transplantation associated with autoimmune-like disease and by fibrosis. Early detection of this complication and the risk stratification according to the level of biomarker is important in the management. Combining the new cell-free DNA markers with the standard biochemical markers could discriminate between patients with or without acute graft-versus-host disease in many studies, because they reported significantly higher level of total DNA in patients with chronic graft-versus-host disease compared to healthy donors and healthy subjects, and also compared to transplanted patients but without chronic graft-versus-host disease. Also, by using the methylation markers, they were able to detect the elevation of tissue-specific cell-free DNA from the skin, GIT, liver, and lung, and to identify the affected organ. Relapse, circulating cell-free DNA, is a highly sensitive marker in the detection of measurable residual disease, which makes it a potential predictor of prognosis. The plasma may show evidence of relapse at an early stage. In early stage compared to peripheral blood, of course not compared to bone marrow. Compared to a sample taken from peripheral blood. Circulating cell-free DNA in transplantation can detect residual disease through the identification either of disease-specific mutation, for example, in leukemia, associated translocation or mutation, but also in case of transplantation, we may also use the cell-free DNA sample to perform the chimerism testing technique done after transplantation. Many studies reported the use of the sensitivity of the use of cell-free DNA in detecting relapse after transplantation, because early detection allows early intervention. And they reported that combining plasma-based detection of chimerism with the plasma-based detection of specific mutations specific for the leukemia, which was detected in the leukemic cells, might also add another level to improve early detection of relapse compared to peripheral blood. And monitoring of minimal residual disease using mutation-specific markers and mixed chimerism using chimerism testing in the cell-free DNA might be useful for earlier relapse detection in patients with myeloid malignancies, and may be also complementary to bone marrow in the assessment of relapse post-transplantation. Final complication, infection. In transplantation, metagenomic cell-free DNA sequencing has been used for screen to identify pathogen in blood before the clinical onset of bloodstream infections, before the development of septicemia. Identification of viral-derived cell-free DNA also in plasma of transplanted patients may be applied using the whole genome bisulfite sequencing technique. Several studies reported that by studying several cohorts of transplanted patients, in these studies, they discovered the frequent presence of cell-free DNA from annulovirus, cytomegalovirus, herpes virus 6, Epstein-Barr virus, and polyomavirus in samples of transplanted patients. Finally, to conclude, liquid biopsy has an enormous amount to offer to people who are having stem cell transplantation. Cell-free DNA is a highly versatile, non-invasive biomarker for monitoring complications after transplantation. Cell-free DNA biomarker may provide an approach for early detection of acute and chronic graft-versus-host disease. Not only that, tissue-specific cell-free DNA may offer a measure of injuries that can be trended over time. Cell-free DNA could also be used as a relatively non-invasive compared to bone marrow source to monitor patients for measurable residual disease complementary to bone marrow and to screen for post-transplantation infections. Cell-free DNA may improve the care of allogeneic stem cell transplantation recipient by enabling earlier detection for its sensitivity and better prediction and monitoring over time because of the simplicity of the sample of a complex array of complications after transplantation. Thank you.
Thank you, Dr. Ghada, for your very illustrative talk. Any questions? By the end of the session?